Good morning. So what I'm going to sort of give a presentation on are some of the universal health coverage alternative considerations that really emanate not from my work, but also from policy processes, which some of you may be aware of and many people might not be. If you look back in time, we actually haven't had one coherent set of proposals for health reform operating continuously since '94. You have some attempts in some of the public comments from the Department of Health and from the sort of the political side of these proposals, who try to go back to like 1941 or something along those lines and say that there's some history to NHI proposals all the way from that period. That is complete nonsense. All of the health reforms at different periods are very much informed by the conditions of the health system at the time. And probably one of the largest sort of systematic set of reforms were proposed in, came out of a commission, a Gluckman commission in the sort of 1940s, which tried to mimic, because of the proximity between Smuts and the British government and the relationship to Churchill, who saw what was going on with the processes that they had initiated with Beveridge in cabinet to create basically a post-war world in which you didn't create incentives for people to support Nazis or Stalins. And so they were thinking very carefully about trying to create a fairer society. And while the war cabinet was continuing in the United Kingdom, you had what was essentially the preparation of a welfare state in the United Kingdom, which was then implemented by the subsequent government, but it was a war cabinet, so you had different parties in the same government. And so Beveridge, we fell under the sort of the Labour Party type of direction, basically then implemented the white papers that were developed during the period of the war under a different government. And there was a large degree of consensus around those reforms, and it set up the NHS. So South Africa, you know, Smuts is hanging around there. Not sure why, but he was. And he set up basically a similar process back in South Africa, where Gluckman tried to look at how our healthcare reforms should be restructured, and he came up with the National Health Service idea and some restructuring. But then the government changed in 1948, and basically most of those plans were shelved. And the issue was, when you go through them, technically they're relatively shallow. From a structural and a systems point of view, but it's not unexpected for the period, because people don't really know a lot about health systems then. Very few people had any idea of insurance systems. In fact, health systems themselves, the NHS becoming one sort of point of departure internationally, where people try to conceptualize a new health system as part of a single process. Most other countries have allowed their health systems to evolve. So, for instance, the UK was on a pathway not inconsistent with much of Europe, which had medical schemes. And a lot of countries in Europe basically created the national health systems out of an evolution of the establishment of frameworks around insurance-based systems. So they're typically referred to as social health insurance systems, but they're very often multi-fund systems, but regulated. The Netherlands, Belgium, a version of it in France, etc. Most of the countries actually fall into that. You don't really have the NHS type model except in very, very small number of countries, and certainly not to the extent of attempted centralization that you had in the NHS. It doesn't mean that the NHS wasn't a successful intervention for its time and for its type of country and its context, which was more appropriate for which had a unitary government and a very small country size to deal with. So just pointing that out, because this idea of some kind of coherent evolutionary thinking process behind what has been tabled in the National Health Insurance Bill is essentially not true. And it is a deception, and is not accurate, and it does need to be sort of properly debunked. There is a history to the evolution of the health system, but it's largely chaotic. And if we look at the post-'94 period, we actually have, I've actually written You'll see some of it in the sort of NHI bill review that I've published, but also published in Health Policy internationally on South Africa's reform pathways and alternatives. And in essence, there have been two kind of broad strands to a reform framework that moved forward. One which basically acknowledged our current system as a starting point and looked at basically stabilizing the regulatory framework for medical schemes as an historical system that can be built on and where its role in a universal health coverage model can be strengthened using the assets that it has evolved over time. And the other part being how you would regulate the state itself as another part of our combined system and how you would harmonize the two. So that's the one model. And in fact, the Taylor Committee of Inquiry in 2002 referred to that as an NHI model. But it's not a single payer NHI model. It's a multiple payer model which accepts, as in many countries, a pluralistic health system which must hang together in order to function well. The NHI proposals emerged out of Polokwane in 2007 and were largely a political proposal, a one-liner. NHI must be implemented through a reform of the public health system, something along those lines. Really not very well thought through, absolutely no research behind it, nothing beyond that line. And since that period, it has been very much, and it was very much part of the political deal that got Zuma into power, because you had a number of constituencies that were quite important to establishing who would be president. And we're seeing the consequences of a lot of that, because the power around the president is immense. And it's a very, very dangerous post. It's very dangerous, given that the powers of the president to influence systems of meta-governance can influence whether or not the government and the state can function. Just on the president alone, you can destroy many of the systems of meta-governance, as we've seen. And to repair them potentially requires some structural reform, which we're not seeing. So we remain at risk at that level. So the battles around who gets to be president are very important. And there are lots of moneyed factions around that. So it's a transactional process. It's not about equity. It's not about achieving harmony in South African society. It's about who can access tenders, who can access licensing arrangements and make deals, who can basically access the systems of patronage using the authority of the state for their own private reasons. And we see this in many kinds of reforms as well that we have, is that you will notice there's a consistent model that is always proposed, not just in healthcare, but everywhere else, where the idea is that using the authority of the state, you establish a state monopoly structure and you prohibit competition to it. So you actually actively prevent somebody else from competing, because that protects a structure that doesn't have to perform. So it's the equivalent now, if we had to go backwards, to say Telkom becomes the only supplier of telecommunications in South Africa and everybody else is banned. And of course, then you're pretty much stuck with whatever they do. And then a lot of time is spent legitimizing that. We see the problem with Eskom. Eskom is the same. So the issue of this threshold, the 10,000 megawatt threshold, is an equivalent. It's basically saying there's a fear of competition, because in fact, if we did want to eliminate our supply constraints in South Africa, you would just lift that threshold and you would watch the production come in. It would just come into the system. You wouldn't have a constraint. So our constraint is largely structural through the way in which our centralized structures are directed in order to foster patronage interests. Because if you're the gatekeeper of such immense power through the concentration, it essentially means that you don't have to do your job very well. That's not really important. The question is whether you can enrich yourself and a particular elite as a consequence. So we see it also in food parcel distribution, prohibiting gift of the givers from giving out food parcels so that state structures can be seen to be the only ones allocating them. The attempt now to preserve the post office by making it the monopoly supplier of all parcels below a certain size. Why would you do that? The only reason you would do it is to protect a totally inefficient public entity whose purpose is drifting from any concept of public value. And this is the danger in these designs, is that they are not designed with a coherent public purpose. They are designed, and they're not designed in order to deepen public value. They are designed in order to strengthen patronage networks. And that's where one has to be incredibly careful. When I look at the NHI bill, The last draft, the draft that's out there that I evaluate in this report, is so poorly conceived. The actual quality is so poor. If I were to design a single-payer NHI system and create a plausible bill around it, it wouldn't even be that bill. So even with the same intent, I wouldn't create this garbage. It is such nonsense, the bill as structured. And I'll just make one or two comments on what Patrick has mentioned before, including references to the revenue sources to this fund, shows complete ignorance of this, how the state operates. Yeah, it would convert it into a money bill if those sections actually had any legal effect, which they don't, because it's not a money bill, which means that they mean nothing. They're just kind of advisories to somebody else that we can receive revenue from these sources. But you don't have to put that in a bill. You can put that in a policy paper or somewhere else. All you have to do in a bill like this is to say that this fund can receive appropriations from the state. That's all you have to say. The rest is up to the other parts of the state. How you design your revenue-raising system for the state is up to the state. You don't put it in a bill. So it can't actually create its own revenue sources through a bill. That shows ignorance. The way that they've designed many parts of the bill through how they would operate various entities that they would establish for purchasing are just nonsense and shows even ignorance of the Public Service Act. So I think that the bill as it stands now certainly cannot be implemented, and in discussions I've had with the various people responsible for this, they're clearly acknowledging that this is a dog's breakfast and they clearly want to clean it up. So the first issue is that after 11 years of some sort of government process, to come up with a dog's breakfast as a piece of legislation is indicative of the quality of thinking behind this policy framework, and suggests that there really isn't much. There is also no analytical framework that supports both the rational aspects of the bill as well as its reasonableness, which are clearly important from a constitutional perspective where you are taking people's rights away in this bill. So the reasonableness tests that would be asserted in this framework are required that you've done. There's no underlying work that is being done to show why this has a coherent public purpose. And the problem is when you read through that bill, I could spend 100 years writing stuff on just how stupid the bill is, and it's just a waste of time because it's never ever going to be implemented as such. So, but the point is, where does this leave us as a process? It means that we do have to look at the alternatives. And I just wanted to make one or two just quick comments that Patrick kind of sort of raised that I think are worth noting. On medico-legal claims, I mean, I look at this quite intensively. The contingent liability runs into the sort of 150 or so billion rand. Contingent liabilities aren't what the state pays. Those are matters that are yet to go to court. The actual amounts that are paid out every year, the amount of actual paid out claims that amount to roughly about 1.2% of overall expenditure, which really isn't a great deal. What's interesting is that that's what, say, Gauteng would be paying out, but the Western Cape only pays out 0.3% of its budget, which shows they run their services better. They're not actually creating cerebral palsy children at an industrial scale as they're doing in the other provinces. So the issue is the clinical governance structures in much of our provincial health system are non-existent. And in many cases, I mean, there's so much to say just on that issue. What's it telling us about the systems that are in operation in our public services? There is no review of those cases because they want to defend them. So they want to say, we're not negligent. So they don't investigate them as negligence, and they don't fire the CEOs responsible for what must be a systematic failure within that particular hospital. So what they do is they just allow the services to continue as they are. So where is the consequence to failure at a clinical level that is systematically resulting in the failure of these labour wards and the services that are immensely important to mothers and children. So the maternal mortality ratios in South Africa match what we're seeing. We're over 4 times the level of maternal mortality deaths in South Africa in the public system than we are in benchmark countries to South Africa. So where they might have 44 maternal mortality deaths per 100,000 live births, in that's comparative countries to South Africa, your Chiles, your Brazils, your Argentinas, etc. South Africa has over 130, which shows that on an outcome indicator, we are a subpar performer deluxe. And that is a consequence of how we're managing those services, not our resources, because we're actually spending more than those countries on our public system. So there are a lot of things that need to be investigated very carefully in our system, and we need to be focusing on how we address those flaws and faults. So I'm going to run through, but I did note again, just on a quality check, given the trouble that the Minister of Health is in at the moment, on whoever writes his budget speeches and things like that. I did notice that in the budget speech, when they referred to the medico-legal claims, instead of saying 130 billion rand, they said 130 million rand in contingent liabilities. They said these are huge amounts that the state can't afford, 130 million. That's roughly what they've paid for, digital vibes. So I think I think it's worth actually looking systematically at the historical reforms in South Africa, because in fact quite a lot of policy work has gone into these. And one of the latest processes has been the health market inquiry. And these are actually not part of a single coherent process in government. So as I pointed out, I've got the references if anybody's interested in actually reading the underlying reports. So I think the first issue is just to talk about our context. We have kind of two systems. Somehow it's interesting how many fires do affect the public health system. But a point about it, again, you kind of look at proxy indicators of what's going on overall within the health system. And the public buildings in a health system are actually run by a separate department. The maintenance and the investments are run by works departments. In the Gauteng Department of Health would be the Department of Infrastructural Development. And what tends to happen is that they top slice all the money for maintenance of buildings. It goes to this department and appears to disappear into a black hole. And the hospitals have no control over how that department maintains their services. I mean, they've got some control, some influence, they can talk to them. But can they actually impose a requirement to pitch up and fix a ceiling, make sure that there's preventive maintenance in place, that the generators are working, that the lifts are working, that it's not a fire risk, such as we've had at Charlotte. And it's worth reading exactly what they found at Charlotte in terms of a fire inspection, the stuff that is improperly stored. These places are meant to be audited by the so-called Office of Health Standards Compliance, who's meant to be accrediting organisations who will be allowed to contract to the so-called NHI. But on the private sector side, as the health market inquiry has pointed out, some of what the apparent slickness of the system and how it operates is deceptive. It's a very costly system, and there's structural increases in costs that are diminishing the quality of benefits that are available to people over time. It's a complex problem to address. And if one feels that both these systems have assets that you don't want to burn down, and these ones that you don't want to just turf, then you've got to understand the systems that are resulting in their particular failures. Understanding exactly how these systems operate is where you start. It's not coming up with some kind of abstraction of a health system and then saying we want that one. Because if I say I want to create a rocket to the moon, I can create a plausibly looking rocket in an afternoon. It's not going to fly, but I can clearly draw one and potentially make you even think that I know something about it. The reality is that you put me in a position where I've actually got to make that rocket, it's not going to fly. Now that's what we're doing pretty much with our health systems design. You don't start from that point. You have to have people that are invested and understand these systems at a very deep level. And they're the people that are prioritizing what you need to fix next, because there are many problems in both systems. So the health market inquiry tried to look at this as a system. It could have looked at it as, oh, there's some people who are basically colluding and we need to put them in jail. Oh, they're colluding all over the place. There are people paying kickbacks all the way through the private health system that are distorting how the system operates and functions. So the question is, how do we address that as a system? Because you can arrest a few people and stop them, but it's not necessarily going to change the system. All you're going to do is change the players in the system. Very much the same in the public sector. We have the perception that we're following up corruption, but corruption is only a proxy indicator for failures of performance. It's just an extreme indicator. It's coming to the surface that you have this extent of blatant, barefaced corruption that ministers can stand there and say, I knew nothing about all of my friends getting these contracts. I know absolutely nothing. I just don't know how it happened. They're speaking to me every day. They used to work for me yesterday. They're now in this company. They're sending massive invoices into this organization that I'm meant to be in charge of. And I'm the one who wants to be in charge of NHI, but I have no idea where these guys are getting their money from. You know, who's hiding what from you then? The issue is that is part, again, of a systematic problem, that we've allowed the way in which our public service is designed to actually allow the executive to interfere in the administrative decisions of the state. That includes public entities, it includes the administrations themselves. So by not having created a coherent barrier between the administration and the executive, we've effectively created the state capture opportunities. And I want to distinguish between petty corruption, which is what Nicholas Crisp would target when he talks about what NHI will eliminate, and he's going to put in all sorts of systems, promises, that will eliminate corruption in NHI. But nothing will deal with the structural separation of the executive from the administration. And it's your ability to appoint everybody on every side of every contract that gives you the ability to capture. So state capture is capture. It's not petty corruption. It means that you are in a position to control the entities that have been set up and use the authority of the state for private gain. So somebody who's basically stealing stuff from a hospital is not using the authority of the state to steal. The person who's using the authority of the state to steal is the person who's basically allocating tenders, who's licensing organizations and won't license you unless you pay kickbacks to the governing party or to yourself. Those are the risks that are set up with a badly designed system, and until we address that systemic gap, our public systems will not operate effectively because they are not focused on resolving the problems of attempting to provide healthcare and public value. So these two require a solution. The reality is that you cannot create a final solution in abstract and chop both of these systems and put them into a third system that you've never had before, which is basically what the NHI bill purports to do. Without any understanding, it's very clear from the bill itself, no understanding of the current systems. The people who drafted that bill cannot understand the South African health system at anything but the most superficial level, you know, the equivalent of media reports. So if we had to look at a 5 to 10 year scenario with where we are, can we just stay still? And I'm just going to, sort of just run through a risk. If we do nothing, what's going to happen? Because these are systems, they're kind of tankers moving in a particular direction slowly. The medical scheme system, if we have no systemic reforms as proposed by the health market inquiry, it's possible that we will see, due to the cost increases, we see Discovery putting out a sort of 5.9% increase on its contributions this year. 5.9 despite the fact nobody went to hospital last year. Massive surpluses. Their costs went down, they didn't go up. 5.9% is going to be the baseline for the cost increase going into 2022. So then they say, no, it's the average of that. You just have to look at the average increase is just half year of this 5.9% increase. No, it isn't. It's going to create a baseline for the 2022 increase. So it's a massive increase. And it's not justified by the costs that the medical scheme actually incurred, plus the projected costs going forward. It's based on nothing. It's just, as many people in the insurance industry know, keep the people paying high premiums, get them used to it. Don't stop them getting used to these, because then the next time it becomes more difficult to introduce these increases. Now, we do have in the system, the market inquiry is saying we have a hugely concentrated system in which there are vertical and there are horizontal relationships that are causing similar problems, but not the same, in exactly the same, but similar kinds of problems that you'd find in the state. Very few gatekeepers. And a private sector, when it has very few gatekeepers, does not have a free market. It does not have a well-functioning market. It basically has people who can determine what happens to you. And if you don't like what they want to do to you, basically you can stuff it because there's nowhere else to go. That's the whole point of a monopoly. So the risk going forward is that we will see systematic de-insurance. You will not see a collapse. And the systematic de-insurance is basically your high-risk groups, your pensioners, etc., lose any access to a cross-subsidy within the medical scheme system. Their pension systems no longer support them in the post-retirement period, and they are the high-risk group that insurers should cover. But they're also the high-risk group that hospitals in the private sector depend on for their income. They're not there for the young and healthy. We've capitalized the private health system on the basis that we've got lots of old people, lots of people who are sick with chronic diseases, lots of people who require oncology, etc. Well, if you eliminate the post-retirement group, don't expect them to come to a private hospital. So the risk there is that there's a de-insurance which has a knock-on effect on the provider system, with the possibility that in fact there's been an overcapitalization in the private system. That will be revealed. And the market inquiry indicated that. There's a concern there that in fact the supplier-induced model that has driven the growth of the private health system to date, which is problematic and driven up costs, has also resulted in a potential overcapitalization that basically was very useful under COVID, but could prove to be problematic down the line when the patient demand starts to dry up because the medical scheme membership structure has changed materially. So what you have then is an out-of-pocket market for primary care which will expand because people who drop out of this system still buy their services that they can out of pocket. As people dependent on the public sector, you're going to continue to see institutionalized corruption relying on the failure of efficient quality of care, particularly for major medical services, and you'll still have deficient primary care. Consequence, out-of-pocket market for primary care will expand, but that's not an insurance market. So the non-insurance market continues to expand, and more catastrophic care ends up in the out-of-pocket market, and that's the risk. That's when your systems of financial risk protection are starting to fail overall. You also don't have cradle-to-grave coverage. So fiscal pressure will make sure that the growth, budget growth is below the growth in the catchment population as well. So you'll have a declining per capita value in the state services. So this, when you look at it, when we do nothing, there is a problem. And this is the problem that if we had people in government who were doing their job, they would be focused on. But I can tell you now, the health market inquiry is going nowhere in the state. They don't actually have anybody to understand it, firstly. They don't really understand how to use the institutions of government to actually implement any of those reforms. The capability within the National Department of Health has been stripped to nothing. It is really very, very weak. And that's one of the reasons the test for that, the proxy indicator, is the National Health Insurance Bill, because nothing but an idiot could have drafted it. It's so out of touch with any part of our health system that it cannot have been drafted by professionals. That's the only way to look at it. And I have been working in government policy since 1989 to now. Nothing but. This is such a downgrading of the quality of government policy that it is seriously troubling. So how should we conceptualize a strategic approach going forward? So you've got one particular approach is that this might be our existing trajectory. So you could say, yeah, what we're going to do is create an ideal end. I draw my rocket, basically. And this is, we create it in concept. And basically all we have to do is create a pathway from where we are now to that point. So it's a great leap forward. So those of you who can have some sense of China and Soviet history will know what great leap forwards achieve. And they're very much conceived on the same basis. The logic tends to be, with those kinds of conceptions, is that you're looking at an idealized endpoint that typically involves a zero-sum game. Somebody has to lose in order to achieve your endpoint. Plus, no prisoners on the way. The actual consequence of a great leap forward, okay, is that you do actually elicit, you even develop a worse pathway than you were on before. And this is the danger of great leaps forward, of over-ambitious, abstracted policy reforms. So what should one really do? So we're on that pathway. You have a strategic goal. Strategic goal is not an abstraction. It's a compass point direction. It's a penciled in direction. Certain objectives, certain things that need to be achieved over time. Then you realize that you might have to actually almost reverse to get onto a new pathway. You want to get onto a pathway toward that strategic goal, but you're going to have to start somewhere. Here's where you are, you're on this trajectory, but you know that by the time you've started to work on the proposals, you're only going to get to the point of achieving some structural change maybe a year and a half down the line. So you might actually have some static movement within the system, but you want to get on this trajectory and off this trajectory, and that's your first objective. So we need to sort of precisely understand where we are, therefore. What is our current trajectory? By when can we intervene? What is our first best improvement? And what is needed to secure an improved trajectory? That's how you conceptualize a strategic way forward. If you look at what we've got in the NHI bill, it doesn't look like this. Because try and find an understanding of where we are. Anywhere. Out of 11 years, there's no situation analysis. You will have a paragraph on, we have a two-tier system, and we must have a one-tier system. That's it. There's nothing else. So the issue is that a situation analysis in a complex system like this is potentially done in parts of the system. Where is our emergency medical services at this point? You know, it's quite interesting. We don't have a single proper emergency medical services number. We don't have a 3-digit number. We expect people to memorize a 5-digit number at minimum. In some provinces, you have a 7-digit number. And I was at an interesting meeting with one of these provinces at one point, looking at their emergency medical services, and I'd noticed driving up, there were signs with the number on. And by the time I got to the meeting, I couldn't remember the number, because it was too long. So I asked the person in charge of medical emergency services in that province, what is your number? He said he doesn't know. So you think, here's an intervention, an institutional intervention, an emergency number. From 1994 to now, we don't have one. If you now go to an accident scene, what's the likely scenario you're going to face? Is it going to be a public sector ambulance or a private sector ambulance that arrives first? Almost guaranteed the public sector ambulance will not arrive until very late in the day. Something's wrong with a system that does that. So the issue is, it's not that it's private, it's that the public system has failed so badly. There was one very interesting incident I noticed a while ago, and I think we see repeats of it all over the place, where private security had arrested somebody after a particular incident, a car hijacking or whatever, somebody had commented in the newspaper that the police hadn't arrived for 2 hours. And so when the police were interviewed to ask why they hadn't arrived for 2 hours on this particular scene, it was subsequently discovered that nobody called them. So again, those are the things that are telling you something about how the system is operating. You don't bother to call the police anymore because they're not going to come. If they come, they're going to be too scared to do anything. You call private security, and that's a problem, because private security can't solve many of our security requirements, personal security, investigative results. We now have more money being spent on the VIP protection services than on the Hawks. What is that telling you? They cut the budget of the Hawks and increased the budget of VIP security, of the VIP services. What country does that? So the point is that in our public health system, there are many problems that mean that you've got to look at emergency medical care, hospital care. You've got to look at the governance arrangements for the academic hospital system, which is potentially different to that for regional and provincial tertiary care, because you've got co-stakeholders involved in those arrangements. Who owns them? How is money to be arranged? Are you going to look for those academic services to have multiple points of service, multiple sources of revenue for those facilities? They're immensely complex. We have no process to examine the future direction of academic hospital services in South Africa. That's a big one. Nothing for emergency medical services, nothing for forensic services, which are sitting there with piles of stuff that's unprocessed. So how are you prosecuting all of these criminal cases when you don't actually have the forensic services operating efficiently under the control of the Department of Health in the provinces? No proper institutional structure or design. Mental hospital services. A specific design is required around mental hospital services and a governance framework around them. The clinical governance frameworks that I mentioned are quite critical to the well-functioning facilities, whether private or public. You need to have a regulatory framework around that. You need to ensure that there's independence in the investigations, that nobody from a political party can interfere in the investigations. People are terribly scared within the provincial health services of actually having an independent regulatory structure that can actually investigate medico-legal, the medical negligence and adverse events. And the Office of Health Standards Compliance is all appointed by the executive of the National Department of Health, national government. Minister of Health appoints everything in the kitchen sink again. So it becomes a political decision as to whether or not they investigate or do not investigate, or whether they get more personnel, or whether they get more powers. That's not how a regulatory structure operates. So there's all of that. So your quality assurance framework, your approval of private hospital systems and how you regulate them. Each province decides by itself, and MEC decides on who gets a license. All sorts of odd decisions happen at that level. They collect no information on the private hospital system. They couldn't even supply anything to the health market inquiry on the licenses. They have no idea. They can issue licenses for numbers of beds, but they don't actually even know how many actually get activated. We basically don't have a government in charge of our public health system. So the issue is that these are the areas where we require consistent, considered reform that is prioritized. So, so the weaknesses in the current NHI proposals is very quickly, they're over-optimistic about the achievability of the endpoint. There's a misdiagnosis of systemic weaknesses in the health system. Misdiagnosis is actually being a little kind to them. There is no diagnosis. Capability weaknesses in the state to take forward even achievable strategies are largely due to institutionalized patronage that has largely destroyed the integrity of state structures. So the issue is the capability of the state is severely damaged. It can't do things. The retention of unaccountable patronage-based governance approaches for all proposed organizations and regulatory frameworks continues. Every regulator is a ministerial appointment. That's why you have the Health Professions Council running off its mouth in Parliament about the NHI bill. Is that an independent regulator? Anybody that's going to have any independence would be shut up in our current structure, because politically you're not allowed to say anything that isn't approved. So the fact that they've said that means somebody's condoned it. It's not because it's actually a real voice that's coming out there of somebody who's really thought about the future of the health system. It's some political deployee sitting in that organization saying this stuff because it's convenient for it to create a noise of a sufficient kind, to signal where they stand. And the stuff is just crazy nonsense that comes out of that. So, by the way, if you take it seriously, I mean, don't lose sleepless nights over it. They're so far off. They have no idea what they're saying, don't understand the issue. They're merely signaling. And nothing of what they say will actually be implemented. So institutional proposals involve destroying existing coverage approaches before new ones can be tested and implemented. There's nothing being implemented. We've had 11 years of so-called pilots. Pilots have tested nothing. So there's no actual kind of a realistic assessment of systems and processes and testing any part of the proposals. Nothing. The pilots revealed nothing, did nothing, were not systematically implemented. And if anything goes to court in future, and one is basically asking, what did you base A, B, C, or D on? They can't refer to their 11 years of billions of rands spent on pilots that did nothing, in which they didn't even have a proper system of evaluation. It's fiscally impossible. So one thing, just to be clear, I mean, the intention is to increase taxes equivalent to what we're spending in medical schemes. And I have to hear, I mean, people like Nicholas Crisp, they're not people who understand public finance. There is no way that you can increase taxes equivalent to what people are spending in medical schemes. We're at the ceilings of the tax bases. If there is additional money that is raised by the state, I can tell you now it's not going into NHI. It's going into other priorities. So the issue is, you can't say, we are going to get this money. So the question is, what are you creating the institutional framework for? Because you're never going to be able to substitute the medical scheme system practically. Because the money that people pay into medical schemes is in fact not raised by taxes, it's voluntarily contributed, which means there's a willingness to pay it. That's not the case with taxes and how tax bases operate. So there are constitutional challenges likely on the financing role of the provinces, which has been pointed out. And I just want to make this point clear, because Patrick has made a point about it as well. But I just want to make another aspect clear, and I'll sort of reinforce it a bit if I'm not running out of time, is the issue is that the role of the provinces in the Constitution is that they have autonomy. And we have this system of an unallocated conditional grant that goes to the provinces, and it's important to understand the logic of that. You see, South Africa had two options. I mean, as part of the discussions on designing the overall fiscal federal framework that we have, I do know why these things were done in the past. The issue is that you could either allow provinces to raise their own taxes and then implement a tax capacity equalization mechanism, so that you share the fact that Gauteng can raise more taxes than Limpopo. So you actually have Gauteng raise the money, and then you create the equivalent of an equalization fund out of the tax revenue to ensure that all the provinces share the revenue that are raised by the provinces. Now, it's important to note that that logic is consistent with the idea of provincial autonomy, that you raise your own taxes in order to prioritize your own public purposes and your own public goods and services. That's the logic. But it was thought it's more efficient to just have government raise the money from national taxes. It's easier and quicker, and then allocate it down through an unallocated provincial equitable share framework. But it's important to note that that allocation is in lieu of provincial taxes. It's unallocated because of provincial autonomy. It's not available for government to just nationalize. It's part of the constitutional framework which says here are all the functions over which provinces can make their own determinations. They have powers to legislate, powers to raise taxes. They have powers to do things. In healthcare, it's a very general statement. It's health services. They can do a lot with that. And only under certain narrow instances is government able to override that autonomy. It's not large, it's narrow. Government would have to actually show that what they're supposedly equalizing or what they're shifting to national actually complies with the requirements for setting national norms and standards, which, I might add, since 1994 they have failed to do. You know, there are no national norms and standards for provinces for a basic package of services. There are no nationally instituted staff to service ratios. There are no nationally instituted staff to population ratios. You can set up those norms and standards even without allocating the budget for them, but you must be careful about creating unfunded mandates, which is a requirement of the PFMA. So when you do that, you must be sure that when you create norms and standards, they must be consistent with the available budget that people have. And you cannot create norms and standards which exceed the available resources, because then they have a legitimate reason either not to comply with the norms and standards or not to spend the money. So the issue is that that structure exists and it's a national competency to set those norms and standards, and yet they've set nothing. They haven't set anything around basic services, protocols for treatment. They've got some formularies that they apply, but you don't require an NHI to have a formulary. They have certain things that are procured on tenders at the national level, at least the prices are set. But that doesn't imply that you take over the autonomy of the provinces to do the rest. But the issue is national government has done about 10% of what its powers allow for in setting those. But now it can't think, it can't conceptualize how to use its powers properly, so it just wants to take everything and put it into that, when they haven't been able to do the minimum up until now, which tells you again, it's a proxy indicator of the capability of the people making these proposals. They really don't understand what they're doing. So, the risks associated with the reforms are that the government basically lacks the capability to take forward any reform framework, even correct approaches, and I think this is a serious worry. The existing proposals are a proxy indicator of general capability weakness. So the question is, what are the hard realities? The fiscal position of government doesn't allow for a consolidation of the health system under one general tax-funded scheme in any of our lifetimes. You can pretty much forget it. It really doesn't matter what a Minister of Health says. It doesn't matter what they put in a bill. It really doesn't matter what Nicholas Crisp says. You can't do it. It just can't be done. So it's a hard reality. The public sector is too infused with patronage to coherently reform for the foreseeable future. The private sector is likely to shrink, increasing the levels of overcapacity on the private provider system. That is a risk. Private assets, however, are more likely to exit the system than to be absorbed by the public system. We would just lose them. That's a danger. It would be better that we have a system that basically uses our assets efficiently and doesn't allow them to disappear. The public system will decrease in availability as demand increases without additional resources. That is going to continuously happen. So how should we think about the problem? And it's important to sort of look at a difference, a conceptual distinction that I'd make between best practices and best fits. It's an important idea to get if you ever work in government, or somebody who's has to look even at a private sector organization and decide on a future strategy. Best practice means you shop around and you find, oh, well, they're doing this in Germany, so we should do it. Or they're doing this in Mexico and we should do it. That's a best practice approach. The problem is that the best practices might be very context specific. That means that the capability requirements are not present locally. So even if you had to look at a country that's at a peer level, what they're doing in Chile can't necessarily be done in South Africa because the political structures are different. The way in which many of the stakeholders are organized are quite different and very specific, so sufficiently specific to make many detailed aspects of a set of proposals unviable in your context. So you cannot say, oh, well, you know, they have a particular kind of process to run their primary healthcare system. Well, you can't just cut and paste it. So this is actually what happens, is that if you attempt at best practice, very often this is your capabilities, and capabilities refer to your sort of institutional logic, your explicit, implicit rules, your behavioral norms, your trust levels. All of those things are very important to explain your capabilities at a point in time. And here's your task you give yourself because you went and chose or cut and pasted something from the UK. Okay? You're just going to fail because your capabilities are not equal to the task that you've set. This, to me, screams at you from the bill. This is basically how you take a best match approach, is that you understand your capabilities and you set a task that are equal to it, even if part of your process involves enhancing your capabilities over time. So basically your strategy can involve boosting your capabilities and increasing your tasks over time. If you don't do it that way, every single strategy will fail. And the why they say in South Africa is that we have beautiful policies, but they never get implemented. It's because all the policies are like this. It's not that they're beautiful, they're all stupid. They're not real, they're paper plans. And the way in which you actually implement something that's genuine is that you have to have a complete immersive understanding of your capabilities and understand the priorities that you've set yourself in your task. And so in this task, what you want to do is to make sure that your highest priority targets for policy at a point in time are the most important things you have to do next, because there's an infinite number of things that you may want to do. But there's only a limited number that you're going to attempt at any point. And you have to be clearly focused on what those are. If we had to understand the problem in South Africa, is that in the public sector we have a multi-level system of government and a system of conditional grants required to institutionalize national priorities. So it's important to note that national government also has substantial amounts that it allocates as revenue to the provinces on a conditional basis. So we will give this to you on condition you spend it on your HIV and AIDS program and TB program. We will give this to you provided you're spending it on health, on tertiary services, etc. So these conditional grants in South African government, the largest conditional grants are in health. The governance of the provincial administrations, we have to eliminate political appointments, basically separating the executive from the administrations, and this includes the regulators as well. The institutional architecture, we have to look at the functions to be centralized, functions to be decentralized. The NHI framework says centralize everything, and they will talk about, oh well, no, I promise, we are looking at decentralization. We understand that stuff, but what they're talking about isn't decentralization. Decentralization is when you're allocating autonomy to another level, not deconcentration, where you're just a subunit of a large corporate structure. Those can be efficiency destroying. As everybody in a large corporate structure knows, they have to spend a lot of time trying to find a way to vitalize parts of a large corporate arrangement. And very often that means giving units and substructures a degree of autonomy to set their own strategies and to move forward. That's not what's proposed. What's proposed in this framework is to centralize all key parts of the system. So if we look at the private sector, at the pooling level, we do need income transfers. The issue about the tax credits, it's actually not something to just give away. It's part of people's constitutional right. Our Section 27 rights are being provided for in the medical scheme system, and government is making an allocation toward that which on a per capita basis is less than what is being spent on people in the public system. It is a legitimate allocation within the context of a universal coverage model. And that's because everybody above a certain income does not have access to free health services in the state. It's important to note the state is means tested, and it has been ever since 1948. So the hospital system is not free for people who are on medical schemes, not free for people in households. It's a means test, not an income test. So not that they can actually analyze a means test at point of service. It just creates corruption in the administration. But the logic basically says if you earn too much, you have to pay for public services. And that means that you can be financially ruined accessing services in the state in South Africa if you do not have a medical scheme. So the medical scheme subsidy is actually in substitution for the in-kind subsidy you would have received if you accessed the state services for free. So it's part of a coherent design. All countries that have universal coverage models have a version of this. We just have a very imperfect version which is subject to discretion. So we actually have to design it properly, which is what the Taylor Committee of Inquiry and the rest did. Risk transfers are horizontal transfers. That's basically from people who don't need health services today to people who do. it's worthwhile noting that that's the kind of coverage that people are paying for, topping up their coverage in the private health system today. They're basically paying for horizontal transfers, not vertical, not these ones, the income transfers. They are paying, people who are on medical schemes are paying the vertical transfers because they're paying an income tax, they're paying through taxes into the state system which finances that. So we do have a system that actually of cross-subsidization. So a very limited amount comes back to people in this pool, but a substantial portion of what they're paying in taxes goes into the state. So if you want to improve this transfer between the two systems, then you look at your government budget allocation and change it if you're dissatisfied with it. What you don't do is just take this away, because what you're doing is you're disrupting a system that you haven't understood where you haven't understood the consequences. Because if suddenly all of the lower income people, including pensioners who are just grasping onto coverage, drop off, well, where do they go? They go into the state system. The state hasn't got services for them. So on risk, you've got a prospective and a retrospective framework. So horizontal transfers within this are very important, and this is where proposals for risk equalisation, social reinsurance that you find in the Taylor Committee of Inquiry, the original NHI proposals of 1995, all proposed that you have a risk equalisation mechanism in the system which would finance your minimum benefits. You have to have transparency of choice for users at the funder level, provider level. And you have to have also governance of the institutions, the regulators. And we have a problem here in that the Medical Schemes Council is a set of political appointments. Now, it is not an independent regulator. That's not how regulators should be. It means they're imposing political decisions, and there's the possibility that there's discretion that's introduced into regulatory decisions that shouldn't be there. And the Council for Medical Schemes it has no role in the strategic integrity of the health system, which is what it should have, as would the Health Professions Council if it were properly designed, and as would all the other councils that are set up. And there's the governance of the private actors, which is the accountability of users to the general public. These are areas that do need to be sorted out. Transparency. I have no idea of my choices in the system, and yet we have a private system where the institutional integrity depends on me having a choice. My being able to say I'm dissatisfied with this particular organisation, I need to be able to move to another. If I do not have that information, and if I'm constrained in any way from that movement, the system gets worse, as it does in any political structure and as it does in any state structure that allocates powers to itself, that establishes a state monopoly. I realise I'm running on a bit long. Maybe you can indicate, is it okay if I continue for a bit? Because I'll go through some specifics on a reform framework, which I think might be sort of useful. It's just in the shade there. This basically looks like, this is a sort of a quick and dirty version of our health system. We have a general tax funded system which is funds are appropriated to health. At this level, we pool funds in the public national health system. So when people say we don't pool, we do pool. It's pooled the moment you pay taxes on the basis of your earnings, which we do. You give that to government and they allocate it. That's a part of the pooling. It's a question now as to how government distributes that. If they don't allocate it coherently, the pooling is dysfunctional. It's because government is dysfunctional. We have a system of conditional grants and a provincial equitable share formula, apart from the few National Department of Health functions, which are a small fry compared to overall expenditure. 33% of provincial revenue comes from these transfers going to health. These are then appropriated. So the idea in national health insurance is that there will be no revenue coming to provinces anymore in respect of for appropriation by provincial government. So it's undermining their autonomy over this function. The idea is that they would buy the services from a province. That means the money doesn't come in as revenue, it comes in as a claim. It doesn't come through an appropriation system, it's all appropriated at a national level. So basically this entire system would go. So at the moment, provincial tier organises the financing of healthcare and the provision of healthcare. Private system, we have contributions and we have the tax credit. and we have medical schemes purchasing the care, and we have some benefit and access guarantees through the Medical Schemes Act. And then you have the provision of care, which is subject to the system. So this system is its coherence depends very much on how this works, how well that system works as well. So the NHI, this is the changes it proposes. So basically eliminate the tax credit. So basically it takes the medical scheme system out of the universal coverage model. It says medical schemes are no longer part of providing universal coverage in South Africa. Only this system will be. These are taken away because all pooling is going to be there. This organisation and financing of healthcare is removed at the provincial level. And so you have the provision of healthcare. Provinces basically become providers. They're not organisers. But the Constitution says you have powers, devolved powers, over health services. It's not at the discretion of the state to basically through a mere bill to take away those constitutional powers. So this is what the final framework would look like. Basically, it contracts with facilities, they provide care, and they might contract with the private sector as well. But your universal coverage model, basically parts of that theoretically fall into the system depending on how much money they can appropriate into the single framework. So there's quite a big change, because at the national level of government they don't do any of this now. They don't do anything in the private sector. They know nothing about contracting. They have no capacity for this. So it's a completely untested model. So again, refer back to this issue. What they're setting is, even if it were a desirable objective, it's a massive task. And so it's unlikely to succeed. So let's look at the alternative frameworks that have been discussed in South Africa that are actually in policy papers that government has produced itself. So we start off with the same system. So essentially the blue parts are what have been contained in reports to date on restructuring the health system. It doesn't propose to change the overall architecture. But what it does say is that it's actually going to incorporate the medical scheme system into the universal coverage model much more substantially than at this point. By doing that, it would look at the redistributive pooling of funds, that vertical transfer system. The tax credit would need to be restructured into a per capita allocation, not a tax credit. So it's actually something that you can define as an appropriation every year, not something that MoMo deals with in National Treasury, but something that is actually dealt with by Parliament as an appropriation. This should become an appropriation. On this side, as the Health Market Inquiry has recommended, you have a risk equalisation social reinsurance structure that basically makes sure that the pooling around a basic benefit in the medical scheme system is everybody faces the same position. For those that aren't familiar with those kinds of proposals, essentially what they do is that they mean the end point, the outcome would be that if you go to a Discovery Health or you go to a Bonitas, they will be offering a basic benefit package which is identical in terms of its coverage, but they might be at two different prices, depending on how efficiently the different medical scheme is negotiating. But their prices won't be different because of the demographics and risk status of their medical scheme, because these equalisation mechanisms will have removed that difference prospectively and retrospectively, without going into the technical detail. But what it means as a practical thing for consumers and people working in the system is I can choose the basic benefit package at Bonitas or the basic benefit package at Discovery based on price and some indicator of the quality of the coverage they're offering. In other words, who have they contracted with? Are they actually decent suppliers? Your advisors in the system would be saying, no, don't go with them, their network crap. These are the quality assurance indicators that show you're actually buying into, it might be cheaper, but it's a suboptimal structure. But now you've got an alternative in which you're deciding between alternatives. So this is very often how you accentuate markets and make them work more efficiently, is that you standardize the coverage, the benefit itself, but you allow the providers themselves to change what's inside that package. It's up to them to try and attract people to their packages. So this is the concept that is incorporated in the Health Market Inquiry framework, aside from a number of other features which go to enhance this framework. The pooling part you keep at a national level, but you don't have purchasing at this level. Government doesn't buy the services at this level. It basically transfers the funds to organisations and entities at a devolved level who basically make those arrangements. So technically what's happening in the state is an equivalent to this. This pooling here gets allocated to provinces on an equitable basis, and they have devolved powers to decide how to actually allocate those to get the best value for money. So the architecture doesn't change. But aside from that, all the governance issues that I've mentioned before have to come into this, have to come into the regulatory frameworks. This is a detailed reflection of everything that has been in proposals to date, including ones that have been in Treasury. The framework is quite at odds. It builds on the Taylor Committee of Inquiry, the NHI proposals of 1995, the Interdepartmental Task Team on Social Security, coordinated by National Treasury within government, as well as the Health Market Inquiry itself. So within that framework, you have what I've described as the possibility of 3 different fund pools. A social health insurance dedicated public fund, but it operates as a competitor, as a market maker, as an alternative, as a default scheme within a medical scheme system. It just means that you've got this as an alternative if you don't want to choose that one, or if you don't want to choose that. You will have a universal available to all unconditional subsidy, which crosses all these systems. But if you're in a medical scheme system, this is allocated to you as a financial amount to bring down the value of your contribution. If you're in the state system, it is the funding the care that you provided. It's an in-kind benefit. The medical scheme system would be subject, and the social health insurance environment would be subject to risk equalisation and social reinsurance. Social reinsurance is a retrospective allocation based on actual claims. Risk equalisation is a prospective equalisation mechanism based on the risk groups that are in. This means that these people are all offering basic benefit packages that are equivalent but might differ in price because of the provider systems that they're accessing, but it's their choice. Your provincial health administrations receive tax revenue. There's this component which was discussed in the Interdepartmental Task Team on Social Security, which deals with the mess that we have between the Compensation Fund and the Road Accident Fund on providing services for people who are facing trauma-related emergency services. And the proposal there was really to create a universal national scheme around that, in which you'd potentially reinsure medical schemes for their emergency services, and you would directly fund the state if you're paying for them, if they're accessing them through the state service. But basically, the financial value of this is relatively small compared to the overall cost of the health system. But what it would mean is that every one of us would be accessing the equivalent coverage for trauma-related emergency services, with the possibility of expansion to others. But this would be your only true national health insurance fund, because this is one where you'd pool the funds, but it doesn't mean that you purchase them all at this fund, because you essentially, if you reinsure to medical schemes, it essentially means the medical scheme purchases them, but basically you've compensated them for the cost of whatever or a portion of the cost of what they're buying them for. So this would have been an important component to clean up our trauma-related emergency services in South Africa, but it would require a big systems reform. And public and private providers should be accessed by any part of the system. In other words, you're looking at the public system that can contract with private with public, partnerships, anything can happen. So basically what you want to do is, over time, is to have this system evolve toward, co-evolve in an environment which is conducive toward basically bringing all our parts of the provider system into a shared system, but on a contractual basis, where value makes sense. Under this framework, with all the governance reforms were introduced, the state itself, if it starts to provide poor services, people are going to, if they've got income, they're going to opt into this framework. If this system gets too expensive and the state is providing value for money, people will shift that way. So this basically was a concept which involved creating competition between systems as well as competition between funders as well as competition between providers at every level. This isn't necessarily harsh competition, but this is basically competition which allows for value-adding incentives to be in all parts of the system and becomes an additional accountability feature on all parts of the system over and above your more static governance features. In other words, a market is an institution. It's an institution that applies consequences to people who provide bad value. If you have monopolies, it doesn't work, whether they're in the state or in the private sector. So this kind of framework creates ease of access all the way through, movement across the system if you're dissatisfied. It's not that it's immediate and you make these decisions. If you have just 10% of your population making these value-based decisions over time, it will impact on the accountability of the entire system. You don't need 90% to change behavior. But you have to bring the barriers down to people being able to exercise a degree of choice as a further institutional intervention in order to improve accountability overall within the system. So this is what's proposed here, you might see, is it can be regarded as almost equivalent. Is the NHI any more conceptual, any more of an abstract endpoint? The reality is most of this system can be introduced largely through incremental reforms. So the issue is, if you were moving forward with this as your overall framework, certain aspects of this can be introduced without encumbering any other part of the system. You can actually have self-contained improvements in the system. Nothing here stops you from having a separate process to deal with academic hospitals, public hospital governance, and part of the Taylor Committee of Inquiry recommendations involved devolving public hospitals so that they would become public entities that are essentially operating with devolved powers relative to the provinces, and that they can access revenue from both the state as well as from medical schemes. That flexibility introduced into them gives them much more capability to move forward as part of a sort of universal provider system. But the whole issue is a more sophisticated corporate governance design that reinforced their decentralized powers and ability to function going forward, rather than just being the endpoint of some bureaucratic hierarchy which completely destroys all incentives to operate. So this top-down separation, top-down administrative structure that we have is deathly and can't survive into the 21st century and the rest of it in South Africa. And a final point on that, I think at one point the Minister of Health, I can't remember which one, said part of this was, don't worry, we're going to run the NHI like the Road Accident Fund or something. It'll be like that. It's very interesting. I've had very close, examined the Compensation Fund for many years. Compensation Fund was still operating on paper-driven administration systems right up until now. The medical scheme system converted into electronic billing in 2000 and 2001. The Compensation Fund to date has never actually implemented the technologies that are available in South Africa to date. The hospitals are not operating. They might introduce some billing systems to deal with medical scheme, but it's only for medical scheme members. But they can't even put the ICD-10 codes in them. They only do it for the medical scheme members, whereas actually they should be introducing billing systems across their entire patient group and zeroing the invoice. But what it would mean, the information that you gain, the management, strategic information you gain from a billing system means that you can actually look at your income outgo relative to a patient. Now they only have information on how much a hospital has bought and procured. They have no idea how it left the hospital, mostly in the back of somebody's car. So the issue is you want to be able to have complete information on your system, but we haven't even been able to implement in our public hospitals the systems that are available across the road in a private facility. With technology that now is second nature to much of our private health system, and yet we think our private health system must change. Well, it does have to change, but not that way. So that's sort of provided a lot of detail on sort of reforms. And there's a lot of discussion on many details of those. But to me, the basic premise is that framework that I've mentioned is a compass point. But there are very clear delineated areas that have to be resolved. You do not have to change everything. What you're doing is looking at changes. Even when you look at the medical scheme system and a risk equalization fund, you're changing 3% of the system in order to impact on behavior on 95% of the system. That's a leveraged reform. What you're not doing is saying, I can't actually think of how the system would operate. I have to put it in some other box so that I can understand it. But what I'm going to do is change 90% of the system because I don't like the way it works now. That's not how you do it. Every intervention that I've mentioned there is basically a leveraged intervention. It's a key strategic structural intervention that impacts on behavior and how the system operates. It's not breaking down the architecture, destroying one part of the system. It's not a zero-sum game proposal. It's not saying we think that income earners are bad people and therefore they need to pay more taxes. It's not about saying that the people in the private sector are evil and need to be eliminated and we need to put them into the virtuous public sector, which is running with public sector motives. So I'll finish there.